Okay, I will come back again to this one, and some people are rising. And now I have to share again, and come back to my slide. Sorry for that. And then put it in full screen. So this webinar series have been elaborated by the working group 4 leader, Pavel Kawalek. So you have here the full set of the webinar. So it started in January and it's going to finish in November. So you have the program here. It is also accessible from our website and you can register. With this, I am going to welcome our speaker, Meghna Jani. So Meghna, we have to let people in. So Meghna is a rheumatologist. She is an advanced fellow and also a senior clinical lecturer at the University of Manchester in the UK. So she has been working on digital data and pharmacoepidemiology, effectiveness and safety of biological drugs. And she also noticeably served on the NICE external assessment group for the evaluation of TNF therapeutic drug monitoring diagnostic assessment committee. And more recently, she is one of the co-author of the rapid recommendation for proactive TDM across specialties that has been published recently in the PMJ. So now, Meghna, I am giving you the screen so you can share your slide and we can start with this with the presentation. Okay, perfect.
Great. Can you see my screen?
Yeah, perfect. So please again unmute yourself, mute yourself and switch off your camera.
So hi everyone, thanks very much Jani for that very kind introduction. So as Jani mentioned, my name is Meghna Jani. I'm an NIHR Advanced Fellow and Senior Clinical Lecturer at the Centre for Epidemiology versus Arthritis, Centre for Musculoskeletal Research at the University of Manchester. I'm also one of the managing committee members of the Cost Action representing the United Kingdom. So I was invited to speak to you about systematic reviews and meta-analysis. Given the fact this is a 20-minute talk, this will very much be an introduction to both of these things, but I will highlight some helpful resources at the end if people are interested in learning more. So what is a systematic review? So this is a question that often people ask when they first start out in research and are thinking about conducting a systematic review. So there are lots of different types of literature review that people will be aware of. There are the narrative reviews, which are essentially reviews focused on a broad research topic, and they don't have to be replicable. There are also these scoping reviews that people may have come across, and these are essentially a preliminary summary of the breadth and depth of a particular field of research, and they don't tend to assess the quality of the research that you're evaluating. So a smaller proportion of all literature reviews are these systematic reviews, which use these explicit and reproducible methods to identify, select, appraise, and synthesize results. So systematic reviews answer a very clearly defined research question. They have very clearly defined selection criteria. They often have some form of critical appraisal of the included studies, and they also have some data extraction and interpretation of the data that you've extracted as part of the results section. Meta-analysis, on the other hand, is even a smaller part of systematic reviews. So not all systematic reviews will have a meta-analysis depending on your research question. And essentially, it's a statistical analysis of a large collection of results from the eligible studies that you've selected as part of your SLR. And as I mentioned, very much optional as part of an SLR. So why do we conduct systematic reviews? So given the fact this is a pharmacoeconomic series, I thought I'd start off by talking about the importance in health economics. So systematic reviews play a crucial role in the health economics by synthesizing existing evidence to inform policy, resource allocation, and decision making. So this is a systematic review that I was part of. Jani highlighted this previously. So this was performed in 2021, and it was focused on ELISAs for monitoring anti-TNFs and anti-drug antibody levels in people with rheumatoid arthritis. And this systematic review directly informed the Diagnostic Assessment Committee that informed the recommendations for NICE for therapeutic drug monitoring of anti-TNF inhibitors and rheumatoid arthritis. It can also be really helpful for guideline development. So this was an initiative that both myself and Jani were part of on a European level. So on the left, you see a systematic review on therapeutic drug monitoring of biopharmaceuticals in inflammatory, rheumatic, and musculoskeletal diseases. This was performed in 2022, and then that directly informed the guidelines on a European level. So the points to consider for therapeutic drug monitoring of biopharmaceuticals in inflammatory and rheumatic and musculoskeletal diseases.
Forcibly informed.
Sorry, I'm just going to try and mute others if I can. Okay, so systematic reviews are also the top of the hierarchy of evidence that people may have seen either in other webinars or maybe familiar with from research. And this is because they adopt this scientific approach to consolidate all available evidence pertaining to a specific research question and minimize bias. And unlike other types of reviews, they are classed as original research because of the fact that they follow this rigorous methodology that we'll talk about as part of this presentation. So the very first part of a systematic review or any research is developing what your research question is. And so I quite like this finer methodology or framework that people talk about, which is making sure that your research question is feasible, interesting, novel, ethical, and relevant. And a really nice quote I like in this context is, a good research question should pass the so what test. So getting the answer should usefully contribute to our state of knowledge, which essentially means how important is your research given the current body of evidence, and will it address a clinically or methodologically important question? So a common trap that people often fall into with systematic reviews is trying to address a question that is too broad. So an example is, can artificial intelligence be useful for a personalized medicines approach? So whilst this is an interesting question, it's far too broad for a systematic review because you'll get thousands and thousands of results if you try to address this. A more specific question, depending on your interest, might be to identify and summarize the available machine learning-based prediction modelings related to opioid-related adverse outcomes, which was something that my group, for instance, was interested in. So once you've defined your research question, the next stage is to refine your review questions. And there's some common frameworks depending on what field you work in. So PICO or PICOS is an acronym that a lot of people will have heard of. Essentially, it stands for P, patient, population or problem, I, intervention, comparison or control, outcome, and study or study type if you're using the S. And essentially, this is one of the most common acronyms that we use in the medical and health space. But there are also these other frameworks that I've also highlighted on this slide that people may be interested in. So SPIDER is specifically for qualitative and mixed methods research questions. ECLIPSE, again, another acronym which is used for policy and service evaluation, and then SPICE, which is used for service, project, and intervention evaluation. So if people are interested in some of these other types of studies, I've put a reference on the slide here. But essentially, we'll talk about PICO as a worked example for this presentation. So to take the most recent systematic review that we published this year, which was on machine learning applications in predicting opioid-associated adverse events, The eligibility of this particular example was that patients needed to be prescribed opioids and patients needed to be adults. So that was our patient population, so P. Our intervention was the use of machine learning for risk prediction. We didn't have a comparison because it wasn't appropriate for this particular research question. And the outcome was opioid adverse outcomes, including long-term opioid use, overdose, dependence, and deaths. So how does that then map to the search terms that you will use? So essentially, we then came up with lots of different synonyms that would then fit each of these different domains. So to give you some sort of ideas what this looks like, you would try to come up with some commonly used synonyms. So even if they don't mean exactly the same, we use opioid or opiate, or machine learning or artificial intelligence, because those are the types of terms that we want to capture in the literature. Common abbreviations. So for this particular example, MME, which stands for morphine milligram equivalents, is a very important abbreviation. So we have both the abbreviation and the full form in the search terms. Spelling variations. So often the US English and the UK English have slightly different sort of spellings for exactly the same noun. So here for hospitalization, there's slightly subtle differences. So we've included both of those. A really helpful tip is that if you know that your systematic review should definitely capture 2 or 3 important landmark papers, it's useful to come up with a draft version of your search strategy and then see if your search strategy is picking up those important papers. And if it isn't, then it might be that you go back to those original papers, have a look at the keywords, have a look at the title and abstract, and see what terms then need to be included in your search strategy to help refine it a little bit more. So I would say that the search criteria tend to be a bit more of an iterative process before you get it exactly correct. And you may also need to tailor your search strategy depending on what database you use. So the first one that we always tend to use is Medline or PubMed. And then once we've refined it for that particular database, we then refine it for Ovid or Scopus. So Boolean operators are essentially the terms such as or, and not, which are commonly used in systematic reviews to refine your terms. So or essentially increases your hits. So looking at that previous example, all of the synonyms are followed by or to try and improve and increase the number of hits that you're getting, and will reduce your hits. So if you think about it as a Venn diagram, essentially what we're interested in is that bit in the middle, which will capture all of the eligible papers for this particular systematic review. So the and Boolean operator will allow you to identify that overlap and reduces the hits appropriately. And then there's also not, which you can use as part of your search criteria. I would advise caution with this just because you can sometimes drop some really important papers if you're including that in your search terms. And so my tip would be that if you can, it's better to exclude during the full text review stage rather than this initial stage, because sometimes you do end up dropping some important papers that you don't want to lose. The next sort of strategy is using medical subject headings or mesh terms. So these mesh terms are essentially an indexing system. So to give you a worked example in terms of how you might use this, if you were trying to design an SLR to identify studies on the cost effectiveness of statin drugs and cardiovascular disease, the mesh term for statins is HMG-CoA reductase inhibitors, which is essentially the mechanism of action for statins. So the advantage of using these mesh terms is that if you were to use that particular term, it would capture all statin-related articles, whether or not you use statins or HMG-CoA reductase inhibitors. Similarly, cardiovascular disease is a mesh term, so you don't necessarily need to include all of the synonyms associated with cardiovascular disease. And then cost-benefit analysis is another mesh term that you can use. So it's just a way of improving the search hits that you're getting. So some of the common issues with systematic literature reviews, especially when you're starting out, is getting too many hits. So you might get thousands and thousands of hits, and sometimes there's a restricted amount of time to do these systematic reviews, so it's not possible to go through everything. So you might want to think about if there's any way that you can refine your research question if that happens, or can you tighten your inclusion criteria in some way? Another solution is not using too broad keywords if you can. And then, as we just discussed, using mesh terms or Boolean operators can also help reduce your search hits. So adding more and categories, for example, will help reduce the number of hits you're getting. On the other end of the spectrum, you might get too few search hits. And the first thing that you may want to just double check is there just a general lack of evidence? And is this the right question for a systematic literature review? And if it is, then there might be certain things that you can do to tailor this a little bit better. So you might need more search terms, so using the or Boolean operator, more synonyms, truncation, so using wildcards, for example. Removing unnecessary filters. So we usually tend to include only English articles, full text, a certain date range, depending on your research question. You could try reducing those filters. And then broadening your inclusion criteria or your eligibility criteria can help increase the number of hits also. So some of the key considerations that you could think about when you're designing your systematic review is what is your eligibility criteria? And I would suggest sort of defining this really clearly, both the inclusion and exclusion criteria, because it very much helps at the next stage when you're doing your title and abstract search. Using the PICO criteria will help, and then any other additional considerations. And then think about the date range that you might want to include. Are you looking from inception till the current date, or do you want to try and reduce it? Do you want to just include randomized controlled trials? Just language barriers, if you want to just include English language, and just full text, or include abstracts such as conference abstracts as part of your systematic review. Another really important consideration is using SLR reporting guidelines such as PRISMA. So PRISMA stands for Preferred Reporting Items for Systematic Reviews and Meta-analyses. So these are very sort of standard and easy to follow guidelines in terms of essentially what needs to be reported in a systematic review. So they've published a checklist, and they also have a diagram, which we'll go through in a minute, which is very intuitive, and essentially all systematic reviews that are performed well will follow these reporting guidelines. And then the third thing to consider is to consider registering your SLR protocol. And this is something that has become much more important recently because there are so many systematic reviews being published on lots of different topics. So it's to improve transparency, to almost put your flag in the sand to say that this is a systematic review that you're conducting, but also just to make sure that you're not contributing to research waste. So has anyone already published or is doing a systematic review on exactly what you're planning on doing? And it also allows you to sort of very clearly highlight what methodology you'll be using, how many people will be reviewing things at each stage. So it's just another way of improving the transparency and open science in systematic reviews and in this particular domain. So the PRISMA diagram that I alluded to is essentially the anatomy of a systematic review. And if anyone has read systematic reviews, you'll be very familiar with this. So the first stage of a systematic review is the identification. So again, using the example that I mentioned previously, in this particular instance, we had lots of duplicate records which is inevitable if you're using more than one database. So one tip is to use a type of software that will help identify these duplicates rather than the researcher having to manually do that themselves. So software such as Rayan is free and is fairly straightforward to use. Another one that I would recommend is Covidence, which is a paid version, but also very intuitive and easy to use. And it's especially helpful for removing duplicates, for collaboration, if you're having lots of researchers working on one particular systematic review. And it also helps create that PRISMA diagram for you as part of the software. So the first important stage of screening is the title and abstract screening. And this normally requires at least 2 independent reviewers with a third reviewer to help resolve any discrepancies. The following stage after that is a full text review screen. So this is essentially reading the full text of the articles to make sure that your study is meeting the eligibility criteria, clearly recording any reasons for exclusion at this stage, and just being very transparent about what's in and out. And then finally, once you're at the full text review stage, you might also want to consider something called backward snowballing. And what this means is if you've got important papers, you might want to look at the reference lists of these papers to see if that will then identify any additional papers that your search hasn't. And there's also a technique called forward snowballing, which we've also used, which is basically looking at the citations of these important papers to see if there are any newer studies that again meet your eligibility criteria that your search criteria may have missed. And so it's just another way of just being as thorough as possible, and also including more articles. So when you're at the data extraction stage of the full text, there are sort of 2 important questions that you need to try and think about. The first is, what are the critical domains of your research question? And the second is, how will you critically appraise the quality of the studies systematically? And these are both very important in terms of making sense of what you're extracting. So one way of assessing the quality of the study systematically is using something called a risk of bias tool. So if your eligibility criteria stated that you're only interested in randomized controlled trials, a really good risk of bias tool is the Cochrane risk of bias tool, which was updated in February of this year. It's very intuitive to use. There are lots of very helpful guides if you wanted to use this. And probably the most commonly used in systematic reviews if you're using randomized controlled trials. For observational studies, there's one called Robbins 1 version 2, which was updated at the end of last year. And then the Robbins E tool, which is useful for assessing specific types of exposures, so environmental, occupational, and behavioral exposures. And then for economic analysis, there's the NICE methodology checklist for economic evaluation. And I've put links to all of these on the right on the slide. Okay, so moving on to meta-analysis. So meta-analysis, as I mentioned, is statistical analysis to combine and analyze the results of multiple independent studies on the same topic. The important thing is that if the outcomes are completely heterogeneous, then it can be quite difficult to combine everything in one particular meta-analysis. So the general framework is, what is the direction of the effect? So the association, what is the side of the effect? And what is the effect consistent across studies? Dania, like 2 slides away from my final one. So this is a forest plot, which is the anatomy of a meta-analysis. And essentially, there are some very important domains that people will be familiar with. So on the left, it'll give you the study description, the effect size and the confidence intervals, which are represented through these graphs. Also, the effect sizes on the right, which will tell you the numerical value, the numbers of patients, and then the symbol that looks like the K will normally indicate the number of studies. So this is one example of a risk of bias summary plot using the Cochrane tool for randomized controlled trials. Again, this is a really nice pictorial way of looking at the quality of the studies. So this will assess the association and the direction of the effect. The risk of bias is essentially assessing the quality. And then when it comes to heterogeneity, there are 3 things specifically that this looks at. So you might want to look at clinical heterogeneity, which is the variation of participants, interventions, outcomes, study settings, the methodological heterogeneity, so study design and risk of bias, and statistical heterogeneity, which is the variability in effect sizes, so beyond what is expected from chance. And so people may come across something called the I-squared statistic, which is a measure of calculating the variability in a meta-analysis that is due to heterogeneity rather than chance. And so an I-square of 0 basically means no heterogeneity at all, so you're all good. I-square of 75 to 100, so closer to 100 means more heterogeneity. So that's less good. And so just very briefly, just to mention that if people are interested in calculating this is a very easy thing to do using Stata and R if you've got a statistical background. If you don't have a statistical background, some really helpful tools are RevMan, which is a Cochrane tool, and I'll put a link to that at the end, and SPSS, which is also very user-friendly. So in summary, we've talked about systematic reviews and meta-analyses, which are key tools in evidence-based medicine. When it comes to defining your research question, think about the FINER method and the PICO methodology to help refine your research questions. If I sort of communicated one thing as part of this talk, transparency of methodology is really important. So using Prisma diagram in terms of the checklist and the figure is really helpful. And then also consider registering your protocol to help improve transparency, open science. Just because you've done a meta-analysis and a systematic review doesn't necessarily mean that you've done a good job. So to try and have a rigorous approach when conducting these types of studies, and the results of your meta-analysis definitely depend on the consistency and the quality of the available data. So just to bear that in mind also. So that's my final slide, and happy to take any questions.
Fantastic, perfectly on time. So be assured that I will replay what we have been discussing today to my colleagues. It's very coherent, and it's very explicit way of explaining what is what is a meta-analysis and what is a systematic review. Maybe before we can start with one or two questions. I see that you can open your camera if you wish. I have just one question. Have you? I think it is a very important question. Have you ever used, or are you thinking about using artificial intelligence to do this systematic literature review?
Yeah, really interesting question. I think the methods to use AI in systematic reviews are a little bit in its infancy, and I think people have tried it, and there have been questions about whether or not it's doing what we want it to do. So I think there's definitely potential of artificial intelligence, natural language processing, helping with these types of reviews in the future and reducing the burden on the researcher. I don't think we're nearly there yet.
Okay. Any other questions? So I have one question in the chat, but it's difficult for me to read. Just one moment. Considering your experience, how much reference and full articles are enough to consider a serious study, a serious systematic review?
Yeah, that's so funnily enough, my PhD student asked me the same question yesterday. It's very difficult to tell. I think it very much depends on the research question. I think if your final full text review is yielding less than 5 articles, then it suggests that maybe it's not necessarily enough or a broad enough research question for a systematic review. I think in my experience, probably at least like 10 to 15 full text reviews will make something that is useful, that you can do some data extraction on and have some valid conclusions that will be helpful for the reader. If you have too few results at the end, then unfortunately, I'm not sure how much use there is to the reader who is spending time reviewing your article, would be my thought.
Okay, so maybe we can adjourn the meeting unless there is one last minute question. Or maybe people are very shy today.
That's okay. I think this is a really good turnout, though, is it not?
So thank you very much for this nice talk, Meghna. So the next one will be in a month. So it will be given by Michal Polka from the University of Krakow in Poland. So it will be talk about optimizing therapy and personalized treatment with TDM in clinical trials. So with this, so see you next month. It will be on the 30th of May. So see you in May. Thank you and goodbye.
Thank you. Bye.
Thank you. Bye.